We are live now, ma'am.
Abhishek. Welcome everybody. I'd request Dr. Ashish Fadnis, who is the Bombay Orthopedic Society Secretary, to welcome all the participants as well as the delegates from all over the world who have joined in today.
Thank you very much, ma'am, and a very warm welcome to all of you watching this on Ortho TV, on BOS YouTube channels. A very warm welcome to you on a Sunday afternoon. Today, our worldwide webinar features our friends and our faculty from the Asia Pacific Orthopedic Association, the Foot and Ankle Council, who will be discussing a few things and very interesting cases of foot and ankle trauma and various pathologies. I'm the secretary of the Bombay Orthopedic Society, and without wasting much time, I would just like to welcome everyone and briefly talk about our society and welcome our delegates. The Bombay Orthopedic Society this year is celebrating its 6 decades of existence. We are a society that has grown from strength to strength, and it is because of the doyens or the giants who have shaped our society, who have founded our society, that we find where we are. This is a brief glimpse of the essential members of the society who have contributed worldwide and who have contributed to orthopedics, whose recognition is, whose work is recognized by one and all nationally and internationally. It all began with Dr. Katrak, who was the first orthopedic surgeon in India and who established the first orthopedic unit at the Wadia Children's Hospital, where the convener for today, Dr. Rujuta Mehta, currently heads the orthopedic department. This was the first academic teaching unit in India. And Dr. Katrak also went on to establish the first academic teaching unit at KM Hospital and other hospitals in Bombay. He was the first Indian to be awarded the honorary fellowship by the British Orthopedic Association. So through the years, eventually in 1965, a few orthopedic surgeons came together. They formed the Bombay Orthopedic Society. Dr. Katrak was the first president, and Dr. Ellen Bora was the secretary, along with Dr. Masalawala and Dr. P.K. Mullah Firoz, who were the EC members. They came together and formed the society. This was also supported by the eminent orthopedic surgeons of the time like Dr. Talwalkar, Dr. Dholakia, Dr. M.G. Kini, and Dr. Masalawala, who played a very key role in establishing the sort of the tenets or the founding pillars of our society. Through the early years, the Bombay Orthopedic Society became recognized as a very good academic body because they would meet once in 2 months. They had bi-monthly clinical meetings, which were conducted at various teaching hospitals. They had a lecture program over 3 days, once in 6 months. And they also constituted what is now known as the Western India Regional Orthopedic Conference, which is held once in a year. And the first one was conducted in 1966 at the Taj Hotel in Mumbai. They started hosting the Johnson & Johnson traveling fellows from different orthopedic sectors. So all in all, foundations for being a good academic body and imparting orthopedic education beyond the medical colleges was being done by the Orthopedic Society. Eventually, as more and more orthopedic surgeons joined in, it gathered sort of momentum. And then came a phase of rapid growth when we used to have more predictable calendars, very robust clinical meetings. We had master series, which were conducted by key opinion leaders in a particular specialty. And they were monthly events and they feature very regularly on our calendar. We have certain flagship courses which are very popular across the country in basic trauma, spine, arthroplasty, and eventually they have evolved in pediatric orthopedics, foot and ankle, deformity corrections, musculoskeletal tumors, and flap courses, etc. We also participate in postgraduate teaching program. So like a exam preparation or a preparatory case presentations are being taken closer to the exams. But more than 6 or 7 such programs are conducted throughout the year in a teaching hospital where Dr. Binoti Seth, Dr. Karkhanis, they take part and they train about 40 to 50 surgeons, 40 to 50 students who are all appearing for their exit exam or qualifying exam in the months to come. We run a fellowship program. Currently, this fellowship program runs for arthroplasty, pediatric orthopedics, and spine, where we invite trainees from different parts of the country to come and visit the surgeons who are based in Bombay go to multiple different hospitals, scrub up for cases, attend OPDs, and do certain observerships. We are also tying with various orthopedic associations across the world to sort of send our members as fellows to different places where they could sort of exchange ideas, learn new concepts, and then come back and practice here. YROC is our premier academic event. It is usually attended by surgeons from about 1700 to 1800 surgeons from India and a few neighboring countries. A lot of foreign faculties, they do participate in this event. And this is sort of the pinnacle of the academic calendar that we have every year. We have a journal, the Journal of Clinical Orthopedics, which is now sort of going to get indexed in the near future in the Scopus, and we are not yet PubMed indexed journal, but we would get the BOAJ accreditation very soon. We have a very good protocols app, which I would encourage everyone to download and use it. This is an app which is designed by an orthopedic surgeon and taking in consideration the current medical legal practice and medical legal scenario that exists in our practice. So these are consenting apps where these are apps which are used for consenting. And there is a variety of orthopedic procedures along with different aspects of information that you would want to give to the patient and the patient's relatives regarding the risk of complications, resurgeries, and things like that, which is there in that app. It is free to use. It is free for everyone. All you have to do is just register for the app. This is again sponsored by the Bombay Orthopedic Society for its members and for every orthopedic surgeon who wishes to use that. Dr. Agashe, who is going to join us, he has done landmark research and practice-changing research in osteoarticular tuberculosis. So Bombay Orthopedic Society does have a corpus where we fund some researchers who would want to do cutting-edge work or practice-changing work in orthopedics, where we can support them. Where do we stand today? We have influenced a lot of orthopedic surgeons across the country, and through our members or through our teachers who have been as faculty, most of the people across the country would know about the Orthopedic Society, and they look to us towards as a good orthopedic academic organization. So we have a strong legacy, and it is a very great responsibility that we have to live up to the expectations, and we have to make it even more stronger. And it is for this reason that we decided to think a little out of the box, decided to collaborate with orthopedic societies across the world, so that together we can elevate the orthopedic care and orthopedic education for our members and for everyone. We do conduct these worldwide webinars are a part of a worldwide webinar program that we have been conducting. We have conducted a couple, which I'll mention, and a few more are to come. There are a few outreach programs where physically the members of our society, the teachers, the senior members would go to different cities across the country and conduct these monthly outreach programs with the local orthopedic organization and sort of discuss on a particular topic through a particular topic of orthopedics. We have 4 live surgery symposia where there are a few curated surgeries which are recorded in a particular format, which are sort of going to be relive. The surgeon speaks about the surgery at a particular moment. This is being attended across 17 to 18 cities at the same time across the country. We have 4 such symposia happening this year. We concluded recently did the hand surgery symposia. The foot and ankle is the next one, which probably will be in the month of September. And we have one on shoulder, elbow, and pediatric orthopedics. This year, we'll publish a series of monographs, which will be released in our annual conference in YROC. And these will be dealing with different and very specific topics of orthopedics where there is a need for some clarity and consensus. We have a fellowship program, which I just briefly alluded to and mentioned. Our monthly master series or bi-monthly master series, the next one will be conducted in Saifi Hospital, and it will be dealing with upper limb malunions and non-unions. And this will be on the 6th of July. The upcoming webinars, the worldwide webinars so far with Dr. Rujuta Mehta's help and with the help of Ortho TV were conducted. The first one was with the Bone and Joint Journal on chondrosarcoma. And this was with Dr. Ajay Puri and Dr. Fares Haddad, who had participated. The next one we had was with the Canadian Pediatric Orthopedic Society. We looked beyond beyond DDH and looked at various aspects of slip, upper femoral epiphysis, Perthes disease, and hip fractures in children. The next one will be in accordance with the World Society of Musculoskeletal Infections conducted by Dr. Vikas Agashe. And the current one, we are very grateful to the Asia Pacific Orthopedic Association and the Foot and Ankle Council of the APOA for helping us conduct this particular webinar. The next outreach program will be in Vapi, which is a place which is close to Mumbai. And this will be the next following Sunday, where we'll be discussing about complex upper limb trauma, the controversies, and arriving at a consensus in the management of upper limb trauma. The live surgery symposium, as I mentioned, the last one was conducted in Jupiter Hospital regarding hand surgeries. There were about 15 to 17 live surgeries which were telecast from 9 o'clock to about 5 o'clock in the evening. It was across 17 cities in the country, and more than 150, about 100 people were there in the audience, and I think more than 200 people were there across the country listening to and watching these particular videos. The next course that is going to come up is a basic arthroplasty course, which is a 7-day course as a part of our flagship event. This is between July 12th to 18th. And here we have got cadaver workshops, sawbone workshops. We would have surgeon visitations. So all the 7 days, 5 days, the delegates or the students would get to visit different hospitals and scrub up with different surgeons performing arthroplasties and having a one-on-one discussion. And in the latter half of the day, they would have small case-based discussion and training via lectures and interesting case scenarios. So BOS is not only about studies and work. This year we also have our annual monsoon picnic. So this will be on the 26th and the 27th of July in Karjat in Radisson Hotel, where we invite everyone to please register for this picnic. It is there on our website. The link is there. So we would, really be happy if every one of you could join us for the monsoon picnic. And finally, the pinnacle or the flagship of our society is VIROC, the annual conference, which will be held between the 26th to the 28th of December this year at the Renaissance. This year, it promises to be bigger than the last few years. We are planning a lot of events where there will be a pre-conference workshop, there will be post-conference seminars or focused training programs on all these 3 days, and a lot of academic activity is being planned for the 60th year this year. So I would join Dr. Gautam Zaveri, who is the organizing chairman. Our organizing secretaries, Dr. Parag Lad and Dr. Chasnal, in welcoming all of you for this annual event. All in all, I welcome you to this webinar. I thank you very much for joining in today. And I would hand it over to I will welcome Dr. Arvind Puri to take things forward.
Thank you very much, Ashish. Can I start by echoing the warm welcome that has been expressed both by Ashish and Rujutha, and thank everybody from the Bombay Orthopaedic Society who have helped organize this collaboration with the APOA Foot and Ankle section, especially Rajiv, Gautam, Ashish, and Rujutha, along with the rest of the organizing committee. Thank you very much. Now, APOA has always believed that the way forward in orthopedics in our region is on delivering knowledge, education, and raising the standard of the specialty of foot and ankle in particular, and orthopedics in general across the region by collaboration, interaction, and sharing of knowledge. And in this regard, this is an absolutely fantastic example of how we can achieve this. The luminous faculty, the best from Bombay Orthopedic and the best from the APOA Foot and Ankle section, are here together to share their experiences and discuss the problems and complications and the way out for some very difficult foot and ankle trauma cases that we are all used to seeing in our practices. I just want to perhaps mention 3 important things. Number 1 is that because APOA has always been one of the foremost organizations to deliver education, we in the foot and ankle section have secured funding to run 4 to 6 2-month fellowships in our region, and we are going to choose the 6 centers of excellence and then put an ad out to get the most appropriate and deserving candidates to go ahead and join and enjoy and learn the fellowships in those centers. So that is one thing I would encourage everybody who has tuned in today to look out for. The second thing is that we have the next APOA meeting in India, in Jaipur in February, and I would encourage as many people as possible to come and attend it, because believe me, it is an absolutely exceptional meeting with such a wide range of topics and speakers, along with the dissemination of knowledge, that you will find it's worth the visit. Last but not the least, I think collaboration is the way forward. And this is a really good start. And I would encourage both the APOA as well as the Bombay Orthopaedic Society and the other regional and national societies within India to collaborate with the different specialties and take this even more steps forward. Thank you very much.
Thank you, sir.
Thank you, Dr. Puri. I think that is very, very kind of you, and so nice of you to invite all of us to the APOA Jaipur. And without much further ado, I would like to now begin the webinar and start with introducing the man who pioneered a specialty when few of us who were students hardly even knew that it existed. Dr. Rajiv Shah, the captain for today, is the director of foot and ankle surgery at the Global Hospitals Vadodara and Surat. He was fellowship trained at Columbus University in USA and other centers in USA as well. He's the first foot and ankle surgeon of India, truly speaking. And I'm sorry. He's the past chairman of the Asia Pacific Foot and Ankle Society, the past president of the Indian Foot and Ankle Society, honorary foot and ankle surgeon to the government of Gujarat, and winner of the Best Book Award by the Bombay Orthopaedic Society, translated into Portuguese and Chinese. I hand over the proceedings now to Dr. Shah. I can help continuing to take the PPT ahead.
Thank you, ma'am. Thank you for the kind introduction. Can we go to the next? Yeah, Dr. Arvind Puri is my immediate successor as the chairman of APOA Foot and Ankle Council. He is an adjunct associate professor working into James Cook University. He has been invited as a guest editor of our own journal, Journal of Foot and Ankle Surgery, Asia Pacific. He has been involved into so many lectures, into so many book writing. He is presently chairman of Foot and Ankle section of SICOT and has to his credit good number of publications. And it was a very kind of him to agree on a small WhatsApp message that we are going ahead with Bombay Orthopaedic Society. In fact, Arvind, this has been the second time that APOA has associated with Bombay Orthopaedic Society. Last time, while I was chairman, we associated at Viro Global doing a similar kind of a webinar. Welcome, Arvind.
Thank you.
Next person in line of introduction is, can we have the next slide, ma'am? Ma'am, can we move the slide, please? Rujita, ma'am, can we move the slide?
So she's having the
I think
follow. Just
if
Rajiv bhai, can you
I can
continue
be
the
allowed to
introduction
share.
without the slide?
I have my
I think
screen
she may have
ready.
lost connection.
Hope my presentation is seen.
Yes, sir. It's seen.
Yeah. So the next is the Amber Haseeb. She is a qualified fellowship trained foot and ankle surgeon from Malaya, Singapore. Very, very enthusiastic. She had her publication into ISI journal. She had her book chapters into 2 books. She has been an active member of APOA Education Committee as well as Foot and Ankle Section Committee member. She has been APOA Young Ambassador. Some noteworthy achievements which she had was that she had APOA Robert Bose Trauma Gold Medal Award and she had a Mahmood American Best Thesis Award of MOA as a co-supervisor. So welcome, Amber. The next is Dr. Andri Primardhi, one of my closely affiliated colleague at APOA, and he is presently the president of Indonesian Foot and Ankle Society. He has been associate professor into the Indonesian University. He has a publication to the tune of 24 Scopus Index publication. He has also contributed to 3 books and had his fellowships into South Korea and Germany. Welcome, Andri. Moez Ballal, he's a consultant trauma foot and ankle surgeon in Abu Dhabi, UAE. He has been member of BOA, BOFS, IFAS, and SICOT. He has over 25 PubMed Index publications and contribution into 2 book chapters. He is a fellowship trained foot and ankle surgeon at Liverpool, Manchester, and London. Welcome, Moez. And then I'm here to introduce our own 3 Bombay Orthopaedic Society colleagues, Abhishek Kini, who is a fellowship trained foot and ankle surgeon. He has been working into Hinduja Hospital, Reliance Hospital, and Bridge Candy Hospital. He has 16 publications. He has had a prestigious positions and fellowships in London, Cardiff, Amsterdam, and he has been a foot and ankle surgeon to a common man to premier athletes. So his expertise into sports foot and ankle is very well acclaimed. Welcome, Abhishek. He is joining with us from Germany, I guess. Dhrumin has been a fellowship trained foot and ankle surgeon who got fellowship and training into UK. He is presently affiliated with multiple hospitals. He has several national and international journal publications. He has had foot and ankle fellowship at Royal National Hospital at Stanmore. He has had a diabetic and Charcot foot fellowship at King's Hospital, London. And he also had an MIS and sports injury fellowship at Barcelona. Welcome, Dhrumin. And the last but not the least is Dr. Pradeep Moonot. He is again a fellowship trained foot and ankle surgeon, presently working at Breach Candy, Reliance, and various other prestigious hospitals. He has been executive member of American Foot and Ankle Society and past joint secretary of Indian Foot and Ankle Society. He was one such foot and ankle surgeon who got a AOFS traveling fellowship in 2018. He has more than 300 international and national publications in presentation. He also has been a orthopedic son to the governor of Maharashtra. Welcome, Pradeep. I think with this introduction, let's start ball rolling. And can I invite Dr. Andri to share his screen and start his case presentation? Thank you.
Thank you. Yes, I hope my talk is audible and my slide is visible. Thank you, Professor Rajiv, for the kind introductions. Thank you, Bombay Orthopaedic Society, for inviting me. Really glad to be a part of this webinar. I am Andri Primardhi from Indonesia. My talk today will cover about peritalar dislocations, one rare condition, yet potentially disabling condition for the patients, furthermore if it came in the late stage. So as an introduction, we consider the peritalar dislocation as a simultaneous disruptions of the talocalcaneal and the talonavicular joint. Please keep in our mind that the tibiotalar joint in this case is intact. So with intact mortise and calcaneocopae joint. So the problem is on the talocalcaneal joints and the talonavicular joints. Okay, this case is considered rare, less than 2% of all foot trauma, resulting in limited exposure of the surgeons encounter this kind of dislocations with result is a lack of consensus. So it will result ultimately is in lack of consensus and many cases of underdiagnosis and subsequent suboptimal treatment. So actually, this case, if the patients came at the first stage, it's not difficult to reduce and fix the dislocation, but because some underdiagnosis, the patients came in the late stage, so it hindered reduction and fixation. Generally, The peritalar dislocations categorized into 4 subtypes depend on how the injury happens and what structures involved in this dislocation or subluxation. There are 4 subtypes: medial, the most frequent one, the lateral, the posterior, of anterior, when we talk about the direction of the distal part to the proximal part. And we have to always be aware of the associated injuries, such as the neurovascular structures, the tendon, the capsule, or the periarticular fractures, and also the potential complications, not only if the patient is not untreated, but if the patient still treated well, it still have a risk of the joint stiffness, a vascular necrosis of the talus, and also the arthritis in the late stage. So, as happened in every joint in our body, late presentation will have a challenge that result in difficult in reduction and subsequent fixation. Risk of vascular necrosis, of course, it will happen, and then the fibrosis and joint contractures will make the reduction and then fixation is difficult. Not only the close reduction, but also the open reduction is not straightforward as well. So we need to focus on extensive surgical release because there's many soft tissue or hard tissue impinge and being obstacle for the reduction. So this is a treatment option for the late presenting stage. Of course, I think we all can agree that non-operative is rarely successful in the late stage, but in operative also it's not, as I mentioned before, it's not straightforward as well. We have to plan carefully about approaches because the approaches will related on what soft tissue should be released. For example, the Achilles tendon or maybe the talonavicular joint capsule, tendon, and so on. Reduction technique also important. While I think the manual manipulation is difficult in the late stage, also it will pose a risk because the soft tissue injury will have a further injury with the manual manipulation. So sometimes we need the tools to help us to reduce the dislocation. For example, we can use sun screw to facilitate reduction, functioning as a joystick. And also joint debridement will be necessary because there's a fibrosis intra-articularly that we will need to do the debride before to do the reduction. Use of temporary fixation also will be needed because in the late stage, we will need the extensive soft tissue release, in which in turn will make the joint unstable. So I think after the reduction achieved, we will use temporary fixation. Even in some case with the arthritic case or even the grossly unstable, the fusion of the talonavicular or subtalar may be beneficial as salvage procedure. So I will present you two cases. This is the first case. 26-year-old male with minibus driver involved in a car collision, and at first he was brought to hospital, but went home against medical advice. I think it's not uncommon in our region that the patients discharged against medical advice. So the patients came again with their persistent pains and difficult to walk. And you can see here the deformity is considered mild. So I think it's one the reason that the patient thinks this is like a mild condition, and then he went to the some bone setter and thinks that with a simple massage everything will be all right. So upon the follow-up, when the patients come again to our clinic, we found the swelling and slight plantar flexion, but still with no obvious medial or lateral translation, particularly because of the swelling that masked the deformity. So this is the X-ray. You can see there's the displacement of the subtalar and talonavicular joint. If you can note, there's ostrigonum. I think that's one of the cause of the impingement, maybe not only the soft tissue, but also the hard tissues like ostrigonum. And the right side, you can see the X-ray, the CT scan, revealing the degree of the dislocations. So we have to be aware of the obstacles that can hinder the reductions, and we have to carefully plan our plan to address specifically each obstacles. The obstacles can be depending the swelling itself, and then the contracture. Contracture may be the capsule, of course, the capsule and the tendon, Achilles, or the surrounding the subtalar and talonavicular joint that impedes tissue. For example, the tendon and capsule of the FHL tendons, and particularly the button-holding talar head. This is one of the most important things in the peritalar dislocations, because the talar head will buttonhole through the talonavicular joint capsule, extensor retinaculum, and EDB muscle. So this is most important thing, I think, to do the release for the reduction. So what we've done to these patients, first, because the calcaneus is difficult to break down to the distal part, so we managed to do the Achilles lengthening with the open technique. With this open technique, not only the Achilles can be released, but we also can go deeper to the posterior capsule. And if there's some like impingement of the os trigonum, we can do the release as well. And also the fibrosis release depend on how long the injury already happened. And then we can use the joystick reduction to facilitate the reduction, because the manual manipulation is difficult in the swollen foot. And also with you can see the incision of the anterior medial side. With this incision, we can release the entrapped talar head, particularly goes through the extensor tendon or the muscles and the joint capsule. So this is the intraoperative II image. We do the reduction with using a sun screw on the calcaneus and brought down the calcaneus to the distal part and rotated anteriorly. This is the result. Again, we think it would be beneficial to put the temporary fixation, not only the subtalar, but also in the talonavicular joint. And I will choose to avoid to damage subtalar joint and the posterior facet as much as possible. The second one, this is similar, but our approach is different. Also, the patient with mild symptoms, so the patient didn't seek medical advice with relatively looked mild, the deformity. So with swelling, painful. In this case, you can see this is the X-ray and the CT scans. You can see the displaced of talonavicular and the subtalar. So in this simultaneous dislocation of the talonavicular and subtalar, I have an unfortunate experience previously while I focus mainly on the subtalar, but I think in this case we have to put more attention on the talonavicular joints, because I think if the talonavicular joints can be reduced, the subtalar will follow. So the difference with the first case in this patients, we found the arthritic talonavicular joint and unstable due to the extensive soft tissue release. So we choose to do the open reduction followed by talonavicular fusion. This is the result. You can see the talonavicular joint fusion. So this is my last slide. The key takeaways is generally the peritalar dislocation can be managed easily actually in the first stage, but unfortunately many patients came at a later stage that the reduction and fixation would be hindered. So we have to carefully plan our surgical plan, including what approach should be used, what tissue should be released, and how to do the fixation after operation. Because if we do the surgery without appropriate plan, it can hinder the result, the outcome, and also with unnecessary surgical complication. So remember, as the old saying goes, the failing to plan is planning to fail. With that, I conclude my talk. Thank you very much. Professor Rajiv, over to you.
I see a question from Gautam, Rajiv bhai.
So, Dr. Primardhi, thank you very much for a wonderful presentation. Very interesting, delayed. When you say delayed, how delayed did they come to you?
Okay, delayed is relative, but we know that the fibrosis of the joint and the contracture start begin after 3 weeks. So I consider delayed or late presenting if I found that's difficult in the manual reduction, manual manipulation, and if we need the surgical open reduction, open release, I think we can consider it a delay. But I think more than 3 weeks, we have to consider to do the open reduction. We have to prepare for that rather than merely prepare for the close reduction, Dr. Gautam.
So I'm going to ask you the other question. If patients, most of us see patients who have come with an acute dislocation like this.
Yes.
In that case, your attempt would be to do a close reduction and just a splint, or would you even put a K-wire or fix the joints in these cases also?
Okay. Yes, thank you. In the fresh case, I think I have some fresh case. It's easily be reduced by putting a foot on the lateral side and a forefoot on the lateral side, and the joint is reduced comfortably. So depend of the patient's body habitus. If the foot is, I think the size of the foot is small, I think the slab, posterior slab is enough. But if the foot is large enough, I think we will need some K-wire for 2 or 3 weeks.
Yeah. So generally, when we were training, I have given up doing ankle foot more than 30 years ago. But when we were doing training, we were asked to put a Steinman pin in the calcaneum across and then manipulate a reduction. And once the reduction came, we actually took out the Steinman pin. It was usually fairly stable. And we just splinted the patient in elevation for the swelling to go down. Once that happened, casted it. Is that similar to a treatment that you would do?
Yes, yes. Sometimes depend of the patient's body habitus. I think if after reduction is stable enough, I'll still put, maybe I'm not putting a sun screw or K-wire. The cast is enough to prevent any further injury, just for protection, I think, in the fresh case.
Thank you. Any other questions from anybody? I just read a question on the chat box.
Yeah. There's a question from Dr. Kamal, President of Indian Foot and Ankle Society, that why do you put Steinman pin into calcaneus?
Yes, thank you, Dr. Kamal.
That's probably...
Yeah, I put the Steinman pin and the calcaneum to facilitate reduction because in such case, we cannot do the manual manipulation for the reduction of the soft tissue. So I put the Steinman pin or sun screw to facilitate reduction. So I brought down the calcaneum to the distal part and rotating in anteriorly. So the Steinman pin is functioning as a joystick to facilitate reduction.
Thank you very much. I think we will go ahead with the next presentation. Can I invite Dr. Amber
Thank you
to go
very
ahead
much.
with her presentation?
Okay, thank you, Prof. Rajiv and Dr. Arvind for giving me this opportunity. Can everyone see my slides? Yes. So I'm Dr. Amber. I'm from University of Malaya. I will straight away go to the topic because we are already delayed. So I will be talking about posterior tibialis tendon entrapment in a pilon fracture. I will start off with the case presentation first before we go into the theoretical aspect of it. So I have a 54-year-old gentleman with a twisting injury during recreational sports. So on examination, he presented with ankle swelling and deformity. These are his images. So it's a Mason 2B rotational pilon with a Weber C fibula fracture. So as you can see here, Mason originally didn't describe the mechanism, which was added on by Linden. So that's why it is 2B, but we call it a rotational type of an injury, which correlates with the mechanism of injury in this patient. So the discussion points will be what are the management options? So in such cases where you have got complex fracture involving multiple bones around the ankle, you first need to factor whether you're going to go with stage surgery where you go with an external fixator first, or you will go with a definitive ORIF. The second question that we need to ask ourselves is the approach and the reduction strategy. So which in this case, what we need to factor is which will be the best approach to visualize the entrapped tendon, but at the same time for you to visualize the posterior pilon comminution. And since the medium, it extends to the medial malleolus, you do need to decide where you're going to place your incisions so that you can address the medial malleolus as well. And in this case, even the fibular fracture. So now the next question arises, posterior tibialis tendon entrapment. Should it be routinely checked? I will answer this question later, because as we know that pilon fracture, especially posterior, is not as common as compared to the anterior pilon. And also most commonly, the posterolateral fragment is most oftenly comminuted and involved as compared to the posteromedial fragment. Second thing is syndesmotic stability. So how would you assess the syndesmotic stability, and what would be our approach to the fibular fixation? And the post-operative protocol is, when do we exactly start weight bearing? So in this case, it was a low energy trauma. So there was no significant soft tissue injuries. So we could go with the immediate definitive ORIF. Okay, there are papers that compare putting in an external fixator first and then doing an ORIF, or going with an ORIF straight off. So this paper shows that the greatest factor on regression analysis was actually the initial use of an external fixator. I'm not trying to advocate that external fixator is a complete no-no for ankle fractures, but if there is a soft tissue where it's not that swollen, you may attempt to forego the external fixator. Okay, now we talk about approach and reduction strategy. So in this fracture, we could see that it's a posteromedial fragment, and there is a Weber C fibular fracture that's quite high, and it's spiral, so there is shortening of the fibula as well. So the best approach to me would be you either put the patient in a recovery position or a semi-prone position, as shown in the image on the left. You could go with supine, but it will be a lot more difficult to reduce the fracture, and you may need to consider going into a figure of 4. I've always realized that with my registrars, it's always a challenge for them to decide where exactly they want to place the incision, how many incisions they want to make, and positioning of the patient as well, because most of them, they always want to go supine. Okay, so you can see here that there are several approaches to a posterior pilon fracture. You can either go with the PL approach, you can go with the posteromedial approach, which I believe most people commonly do approach, and also a medial posteromedial approach. So for this case, I would advocate going for a medial posteromedial approach, mainly because you want to look at the entrapped tendon, and also you want to address your medial malleolus. So what is the medial posteromedial approach? So it is quite simple. If you can see in the image to your left, it is just in between the medial malleolus and the Achilles tendon, and it can be extended further down around the medial malleolus if you need to address the medial malleolus together with it. So your incision is either lined between the tibialis posterior and the FDL, or you can go between the FDL and the posterior part of the tibia. But I prefer to line it between the tib post and the FDL, mainly because the posterior neurovascular bundle would be out of the way, and also your blood supply to your nerve will also be moved towards the lateral side. So you're not encountering your neurovascular bundle while you are reducing your fracture. Okay, so the way I approached this was, so I went with a medial posterior medial approach. The tibialis posterior is first removed from the entrap. So you can see in this scan that the tib post is entrapped in the fracture fragment. So you have to take out the entrap tendon first and reduce the die punch posterior fragment. There's another thing to note that if there is a die punch posterior pilon fracture, you should always attempt to reduce the medial piece first as opposed to the lateral, because if you reduce the lateral first, the medial will be pushed away and you will have problem reducing the posterior medial fragment. That is why if you have got a posterior medial comminution, it is still better to stick to the medial side rather than going to the posterior lateral approach to posterior pilon. Okay, so how many percentage of cases does the posterior tibialis tendon actually get entrapped, and should you routinely check it? So if you have a CT scan and you have an axial view, if you are able to see that the fracture fragment is entering the sheath of the tendon, then in those cases, 40% of the tendon will be entrapped. Having said this, the entrapment of PT tendon is only about 10 to 20%. Some literature says 10 to 15% even. So you see, if you didn't suspect this preoperatively and you went with a posterior lateral approach because you want to fix your fibula, you would have missed the entrapment of this tendon. So what happens if you miss an entrapped posterior tibialis tendon? There are a few things that can happen. One is chronic. So if you look at image A, which is the preoperative image, you can already see that the tib post is entrapped within the fracture fragment. And 6 weeks post-op, you can see that the tendon has formed its own pathway in the fracture, within the fracture itself. So it's become part of the posterior tibia. This is another case which is showing the anterior comminuted pilon. The other problem that can occur is that the screw, you can see the screw is hitting directly into the tendon, and the tendon is also entrapped within the fracture. So these are cases where you did not plan preoperatively that, you know, your tendon could be entrapped and you end up trapping it further, and it may lead to problems later on. Okay, so now we talk about the syndesmotic and how would you approach to the fibula. So in this case, I would go with a direct lateral. However, if you want to address and look at syndesmotic, you could take this direct lateral and you could bring it a little bit about 1 centimeter anterior to the direct lateral approach. This will help you directly visualize the syndesmotic, because literature does say that the best way to actually visualize syndesmotic injury or stability is by direct visualization. Okay, so now you see the fibula. So if you have a fibula fracture, which is a high fibula fracture, a comminuted fibula fracture, a syndesmotic is involved, or you want to estimate or restore the length of the fibula fracture, to me, it will be easiest to go with either a medial posterior medial or a direct lateral, or you can go with a posterior medial and direct lateral, depending on the configuration of the fracture. If you went with the posterior lateral for these type of fibulas, you are going to have trouble estimating the length and fixation of the fibula itself. So this is just a summary. I'm not going to dwell too much in it. It is just trying to show you based on the fracture fragment, which would be the easy, medium, and hard approach to the posterior pilon fractures together with the fibula involvement. So most of them, if you look, posterior lateral is actually harder to reduce your fibula and also address the pilon at the same go. as opposed to the MPM or the PM. Okay, so this is what was done for the patient that I mentioned earlier. So post-op protocol, there would always be whether you want an early weight bear or delayed weight bear. So what I tend to follow is I may allow patient to weight bear in a cam walker at 2 weeks and start active physiotherapy in a cam walker at about 6 weeks. Depending on the fixation, I may allow non-weight bearing for 2 weeks and then allow weight bearing in a cam walker at 6 weeks. So it all really depends on the fracture fixation and the configuration intraoperatively, and also the quality of the bone. And what I tend to factor in is patient compliance as well. If I feel that a patient would comply to the post-operative rehab, I may start weight bearing in a cam walker a lot earlier. And if you look at the WAX protocol, which actually looked at, it was a multi-center study, which looked at whether starting early weight bearing and late bearing in ankle fractures is early weight bearing inferior. So their findings were that early weight bearing in ankle fractures is not inferior to delayed weight bearing. So identification would be what I advise. So commonest, posterior tibialis tendon entrapment is commonly entrapped in pilon fractures. It can be entrapped in trimalleolar fractures as well. Most often, the posterior medial component is involved, and preoperative surgical planning CT scan is essential for such type of fractures. And you will realize that if you are trying to reduce a pilon fracture, if you're going to have difficulty with reduction, you may need to consider that the tibialis posterior tendon is entrapped, because PT entrapment is one of the commonest causes that hinders reduction of your PM fragment. So what happens if such cases are missed and they present late and the fracture is fixed? Patient may present with eversion of the ankle and foot, pain on movement of the foot, and in a lot of other severe cases, you may present with pes planus or even rupture of your tib post tendon. With that, I say thank you.
Thank you very much, Dr. Amber, for bringing out a very important aspect. 1 to 3 studies have come up with significant involvement of tibialis posterior tendon in pilon fracture to the tune of 40%. There is a question that how can you judge on X-ray as well as clinically that there will be some involvement of tibialis posterior tendon? So what are those telltale signs on X-ray as well as clinical evaluation, which will tell or which will make you suspect tibialis posterior tendon involvement?
To me, I would say clinically would be difficult in an acute setting, because you may not be able to move the ankle and stress the tibialis posterior tendon. But based on the plain radiograph, you would be able to see which part of the pilon is involved, whether the comminution is more towards the medial side or towards the lateral side, and how much of your medial malleolus is involved as well. Because if a big chunk of the medial malleolus is involved on the plain radiograph, I would suspect so that the tib post may be entrapped as well.
Will the foot be into inverted position if the tibialis posterior gets involved?
Inverted.
Clinically?
Yes, I think so, yeah.
So that also would be a suspecting point, right?
Yes.
There is, is there any other
it is
question?
rare. It is rare
I
because
guess.
most often the comminution is posterolateral in posterior pilon fractures. But I think it's good to look out for this because it can lead to detrimental problems. And you may have problem reducing the fracture piece itself intraoperatively.
What other cases where you would use MPM approach? What all cases of pilon fracture where you will use MPM approach over and above this medial variety of posterior malleolar fracture?
Posterior. I think if it's a posteromedial comminution with a lot of extension towards the medial malleolus, then I would use MPM more than the posteromedial or the posterolateral itself, because a lot of people say that going posterolateral specifically, you may jeopardize the blood supply to the sural nerve, because anatomically no one is able to tell where exactly is the blood supply to the sural nerve. So I think if I would still stick with the posteromedial, because from the posteromedial you can still approach the direct posterior part of your pilon as well. So for me, instead of going posteromedial, I would prefer to go medial posteromedial for most of the cases.
Would you take NPM approach for your malunited posterior fracture? When you are reconstructing a posterior malunion, would you take MPM approach? Because that is the approach through which you can see where your osteotome is exiting out. So MPM approach would be a go-to approach for malunited posterior fractures. Thank you very much. I don't see any more questions. May I request Moez to... Pradeep, you have a question? Yeah, go ahead and ask the question, please.
Yeah, so a fantastic presentation, Amber. Really great. Just one question. So again, in the pilon, distal pilon or ankle, posteromedial, posterolateral ankle, is your go-to if you have a posterolateral fragment and a posteromedial fragment? Would you do these two approaches separately, or you would do the MPM approach? And what would be your plane of dissection? I know in your discussion you mentioned that you would go between tip post and FDL, and you do not go more lateral to it. But if you have like a posterolateral,
you can. So you can go between the FDL and the posterior neurovascular bundle as well. You can.
yeah.
So I would really base my incision on which side is the comminution and the configuration of the fibula fracture, and also whether it extends to the posteromedial fragment, or it extends to the medial malleolus or not. Because PM comminution we know that it's not as common as PL when you talk about involvement of posterior pilon fractures. So I now tend to go either posteromedial or MPM so that I can go direct lateral for my fibula.
Yeah.
Yeah.
And also, I think with the MPM, you can always, and if you're between the neurovascular and FDL, you can almost give access to your posterolateral fragment also, and you can do the whole posterior malleolus, maybe one plate, two plate, or whatever combination you can get that access.
Correct. I was one of those people who used to do posterolateral quite a bit, but now I have moved towards MPM because like I showed you, you can extend the MPM a bit more anteriorly and you can easily address your medium mal and everything else.
Sure. Okay.
Let me take the last question from the YouTube. The question is, how do you manage your late presenting cases, and is there any role of MRI into this?
If you have a center where you have access to MRI that easily, yes, you can, but most of the time you can pick it up because such types of fractures, you would most often definitely preoperatively, you will get a CT scan to look at the configuration. So to me, a CT scan is good enough to pick up such a pathology. I wouldn't necessarily get a MRI scan, and not every center has the privilege to order an MRI scan that early on, especially if you're planning on an early fixation.
Over to you, Moez.
Thank you so much. Let me just, so can you see my slides?
Yes.
Okay. So I'm going to be talking on talus fracture. So my name is Moez Ballal. I'm a consultant foot and ankle surgeon in Abu Dhabi. That's where I practice. It's a major trauma center. We see all forms of foot and ankle injuries, talus fractures. So I'm not going to be talking about the common talar neck fracture. I'm just going to focus on talar body fractures. And the aim with for the management of these intra-articular fractures is basically you need direct visualization of the fracture line. You need anatomical reduction. You need rigid fixation. Unfortunately, these injuries most of the time don't come on their own. They don't come as an isolated type of injury. So, for example, if you look at this X-ray and a CT scan, so this gentleman comes in with a medial malleolus fracture, lateral malleolus fracture, and a talar body fracture, anterolateral fragment with loose bodies, and you have a die punch articular surface impaction anteromedially. My normal approach for these talar body fractures is a direct anterior approach. But if you look here, you've got a lateral malleolus, you need a lateral approach, you need an anterior approach, you need a medial or anteromedial approach. And you're not going to be having those three incisions. I mean, the soft tissue bridge is already compromised, it's already narrow in foot and ankle. So we have to think a little bit outside the box and utilize what we have. So we have our osteotomy already there. Okay. And plus, you've got soft tissue compromise. So you've got those deep skin abrasions on the lateral side. So you curve your incision just between those skin abrasions. So obviously that's the lateral side. Okay. You have to release the ATFL. You've got your osteotomy already there. Reflect the fibula laterally. You need to keep the attachment of the CFL, sorry, the PATFL attached. Reflected laterally, and you're looking directly onto the articular surface. The other thing is that having released the ATFL, the whole talus can be subluxed anteriorly. So that will give even a better approach to your fracture line. So once you've done your fixation of the talus body, you need to put your fibula plating. Then you need to reconstruct your ATFL and your AITFL. So that's your talar body fracture, and that's your lateral malleolus fracture done. And basically this is done through a lateral approach, and the patient is supine. You'll have a direct approach to the medial side as well. So it's an anteromedial approach. You can have direct visualization of that die punch fragment, push it down, bone graft it, and a medial an anticlined medial malleolus plate. Again, these injuries don't come isolated, like I said. So you have a really bad Pilon fracture, you have a lateral malleolus fracture, talar body fracture. And you can see that's the CT scan. And the configuration of that Pilon fracture necessitates that your approach is going to be an anterior approach or an anteromedial approach. But again, what would you do for the fibular fracture? What would you do for the talar body fracture? Again, your osteotomy is already done there. So would you go through the lateral approach, or would you go through an anterior approach? So in this case, I've utilized the Pilon fracture as my window into the ankle joint. Exactly. So this is the comminuted fracture, lateral approach, anteromedial, anterolateral approach. So lots of questions. So a direct anterior approach, open your ankle joint through the fracture line, wide open. Sublux the talus anteriorly, clamp it, reduce it directly in the direct vision. Again, there's an extension into the talar neck that needs to be fixed. Once that's been done, push the talus back and fix the lateral malleolus fracture. So it's more of trying to understand what are you trying to achieve. Your incision, I think 1 or 2 incisions maximum over the anterior aspect of the foot with or the ankle with at least, let's say, 5 centimeter skin bridge is sufficient. But you have to understand, you have to study your CT scans well. Again, going back to talar body fractures, what am I trying to achieve? I'm trying to have direct visualization of the articular surface, okay? And then most of the fixation will be done, well, not most of it, some of it will be done X-ray guided. So example, again, another talar body fracture. These are not fixed through your standard anteromedial oral anterolateral approach. So whether do you do a medial malleolar osteotomy with this? Do you do a lateral malleolar osteotomy? I think most of you would agree that the medial malleolar osteotomy will be a way in for this type of injury, because you want to have a direct visualization of the articular surface. So why not do it with a scope? I mean, that's your CT scan, okay? So I decided I'll give it a go. So the patient had I've applied the standard traction on the foot with the knee bend to relax your gastrocnemius, and that's the view that you get. I mean, that's the view that you will get with a direct and open approach. So you'll have a look into the articular surface. I don't use any water pumps. I just use gravity controlled irrigation, controlled on and off, on and off. And you see multiple K wires that are used as so Andri mentioned before, to joystick your fragments back into place. Again, those joysticks are based on your CT scans. You know, you need a thick, rigid wires in order to manipulate your fragments. And you can see with this with the scope and with the fluoroscopy, you can have a decent view of your reduction as well. Having said that, you have to be ready to go in if this has failed. I mean, I wouldn't advocate this approach for all talar body fractures, but again, it's an approach in where your soft tissue you've got soft tissue compromise, where you think that you're going to have issues with your wound healing, diabetic patients as well. And these are the incisions at the end of the procedure. I keep them on. Most of those talar body fractures, I keep them on an X-fix post-op, and I keep them on for about 6 weeks, and then I bring them back to the clinic, to the OR to get the X-fix removed after at least 6 weeks, and then I put them in a walking cast for another 6 weeks. Thank you.
Great presentation of different varieties of talar body fractures. Don't you use this transligamentous approach for talar body fractures?
Yes, it's definitely. If I think that it will be accessible and the lateral subluxation or ATFL, basically resection, will be helpful to get the talus out. Yes, it's a described method. It's been published before, and yeah, I wouldn't hesitate. I wouldn't think twice before in using it.
And what are the rates of avascular necrosis in your cases of talar body fractures?
It's a good question. I couldn't give you a number, but the ones that I've followed up, I've got only one case, but these are not common injuries. But I can't give you a specific number, but they're definitely less than talar neck fractures.
And how do you really manage your avascular necrosis following this trauma?
So I get CT scans for them. I get an MRI scan. I'd like to determine the percentage of the AVN, whether it's something that I can graft or something that will need a 3D cage, or it needs a tibio-calcaneal fusion, or a total talus. So it all depends on the percentages.
So my
So
indication was, do you use total talus replacement?
we don't have it yet, but for talar body fractures, most of the time I use allograft. There's a case that I was going to present here, but that was a comminuted talar body fracture where I've used a femoral head allograft and a TTC, so a hindfoot fusion, and I do it as a primary. 6-month follow-up, the head has taken up, but everything is healed in 6 months. But again, those AVNs and the collapse can occur anywhere in the first 24 months.
Presentation, thank you very much. May I now invite Dr. Pradeep for his presentation?
Let me just try to stop sharing. Yeah.
Yeah. Thank you so much. Sorry. Okay, can you see my screen?
Yes.
Okay, excellent. Thank you very much, Gautam, Ashish, Rujita, and Rajiv Shah sir, for inviting me for this BOS Worldwide webinar. So we'll be talking on, so what are common midfoot injuries? Most of the time what we see is wrist frank injuries, which involves the TMT joints, and that's the most common midfoot injuries. And most of the time we require a surgical fixation. But hang on, is midfoot only the wrist frank joints, or are other things there? There are a lot of joints in the midfoot: talonavicular joint, calcaneocuboid joint, navicular-cuneiform joint, intercuneiforms, and of course the wrist frank. So wrist frank injuries are not the only midfoot injuries we should be knowing about. And if you look at the incidence, it's slightly busy slide, but look at that. Though we talk about wrist frank injury is the most common type, but its incidence is only 0.2 per 1 lakh per year, or 100,000 per year. If you look at the chopard, that's usually the 3 to 5% of all foot injuries are chopard injuries. And then, of course, you look at it, the navicular cuneiforms, the intercuneiforms, the nutcracker type of fractures. These are rare injuries. These are underdiagnosed injuries. We should be knowing the mechanism for these, and we should be investigating these kind of injuries extensively by high degree of suspicion, appropriate investigation, and treated appropriately. So I have quite a few cases for midfoot, and we'll go through them as time permits. So here is a 36-year-old female, road traffic accident, swelling and pain over the left midfoot region. And if you can see from the photos, there is a big dorsal midfoot bump which is present, and she came so within 24 hours with that bump and redness. Here you can see there, that's the bump, and it's almost there under the skin area. If you look at the X-rays, you see that that's the X-ray which we're looking at. And most of the time, which in a lot of the places when you have an X-ray for your foot, you will always be given an AP and a lateral view. Always ask for AP and an oblique view. Ask for a lateral view, because here on the lateral you can clearly see something's not right, something is jutting up really under the skin, and that skin is under tension and will give way. So that is very important to diagnose. So what next investigations? Of course, the CT scan was the choice for here to tell you which joints, which bones are involved. And here you can see clearly the whole midfoot. That means the navicular cuneiforms and the wrist frank joints have been involved as well. So what should be the plan? Should we be doing a single stage reconstruction or a dual stage reconstruction? Should we be doing a fixation, or should we be going for a primary fusion? If you were to do whatever, would you be doing a single approach or a dual approach? And if you want to be fixing it, especially if it's a close injury, would you still just do with the K wires? Would you just use screws, plates, or something else? So these are the questions which you should be looking at or answering that. And depending on the expertise available and the other surgical armamentarium things available, we should be thinking about it. So what we did, We did it in 2 stages. In the first stage, put a distractor, external fixator, and then stage 2 with a final fixation. So that was on the table, just with a manual traction. It did not come. And here you can see that's your lateral view. And this is my thumb trying to push that cuneiform into the space where it should be belonging, but I could not get it. So put in a small external distractor, fixator, distracted it, and there you go. You can see it. And the pins are quite easy. You put 2 pins in the calcaneum, 2 pins in the metatarsal, distract it, and you have this distal radius distractor, distracted, and there you are. And I just pinned it with a K wire. Also, you can see how now you can see the alignment much better, what is happening. And that's what multiple K wires were then inserted through the Lisfranc joints or through the base of the metatarsals into the cuneiforms and into the navicular and the cuboid to make sure that the length is maintained, the alignment is maintained. And this helps in your future planning and your future um, plan effectively. So that's my post-op X-ray. And now you can see there's some semblance of foot happening. That's a distractor in place. You can see there was a fracture of the navicular, intercuneiforms are widely spaced, but the Lisfranc joints are reasonably aligned. And even on the lateral view, you can see the skin has been detension. So this was kept for 2 weeks, waited for the swelling to settle down, and then I removed the distractor, let the pin sites heal up, and then take for the final fixation. So there it is. Pin sites have healed quite well. Swelling has gone down completely. And then that was a plan. And this is once you've removed it, you can see how everything looks reasonable in place and went on for a definitive fixation. And what was a definitive fixation? Opened up everything. And here you can see everything had gummed up, a lot of callus tissue had present. So I just wanted to make sure everything has been stabilized, joints were prepared, and a K wires was put from, you can see how the intercuneiform has been widened up. So I wanted to reduce that. So pass a Lisfranc K wire and navicular cuneiform wires were put in, fixed with the navicular cuneiform with a screw, and then multiple plates were put in to fix the midfoot area, basically stabilizing the navicular cuneiform and the intercuneiform joints. I was happy with that. The lateral side, it did not touch anything because I thought that everything was well aligned and stable. That's my post-op X-ray. Did quite well. You can see that's a Symes line. It's quite good. That's a 6 months follow-up. And she went on to do quite well. No issues at all. Another quick case of a midfoot injury, 57-year-old female, history of slip and a fall, swelling tenderness present over the midfoot, but full range of movement. When you see on the plantar side, that's a plantar ecchymosis, and we know the fact that's a telltale sign of a Lisfranc injury. But I think it's more than that. I think, yes, Lisfranc we say, but anything on the plantar aspect, ecchymosis, I think alarm bell should be ringing that there is a midfoot injury. If your Lisfranc joints are good, then you should be suspecting something else. And if you see here, there are a few things happening. Yes, there is a shadow happening here around the navicular joint, but at the same time, a cuneiform, some fracture line is seen there. What do we see? That's what it is. Patient had investigation. He had already come with the investigations. Here you can see on a CT scan, cuneiforms are fractured. That's a transverse and an oblique line. And of course, if we see an MRI scan, because there was some calcification type of stuff happening at the talonavicular joint, and here you can see the tibialis anterior was avulsed and proximally migrated. So these are the two things. So it's not just about the bony injuries, always associate or see for soft tissues as well. So tibialis anterior avulsions are quite rare. It's not well established due to underreporting or probably missing it as well. And elderly patients usually they have like a flat foot. Mechanism is a forced plantar flexion, and diagnosis is sometimes they come with a swelling and they come with like a foot drop. But the key is the examination. So what did we do? Of course, a long approach along the tibialis anterior tendon. identified the avulsion and initially fixed the cuneiform with a plate and then distally attached the tibialis anterior with a swivel lock and went on to do quite well. One more case, 43-year-old male, history of road traffic accident, pain, swelling over the left midfoot region. See the kind of swelling they had come. Skin condition was not too bad. The swelling was not too bad. They had nadir avulsions and other toes, but nothing significant. They were clean, not infected. That is the X-ray. Look at that. That is a significant or a severe Lisfranc injury. But hang on, is it just pure Lisfranc or something else is going on? So it's always important to assess these X-rays properly because it is just not the Lisfranc. You see, there's a significant divergent or homolateral type of Lisfranc, but also fracture of the base of the first metatarsal, and that really needs to be sorted as well. So there it is. That's what needs to be done, and that needs to be fixed. So would we do a single approach or a dual approach? If you were to dual approach, do we do a plantar and a medial or a dorsal and a medial and one more separate approach on the lateral side? So this is what I planned. One was a medial incision and the second incision was between the second and third. Enough skin gap present between these two incisions. So which one first? That's another thing we should be looking at. So the key is to get your first ray or the first ray length appropriately, and then you can fix your second and third onto the first. So approach the medial side, there was a rotated articular fragment which was reduced. Then the plantar beak way of the metatarsal base that was reduced and fixed with a plantar interfrag screw. Key is make sure you do not have threads going too much distal or proximally or on the top because you want to put a plate on top of that. So then you have a dorsal spanning plate which was inserted. Then a medial approach, as I said, between the base, between the second and the third, marked there, reduced it, put a Lisfranc K wire, and put a Lisfranc screw. Once that was done on a low profile diamond plate, or one or two plates can be put for second and third, and fourth and fifth, these are mobile rays and fixed with a K wires. And that was the fixation done. I was quite happy with that. Wounds and everything healed well. There was a lot of scabbing that also gradually healed, and that's all done at the same time. 4 months follow-up, weight bearing, patient was quite well. And only thing his complaint was he has some pain over the great toe on the ball aspect when he's walking. He finds that the first ray is stiff, and then we planned that we removed the plate on the medial side, and all the hardware came out, and immediately he felt much better. Alignment looks good, arch is well maintained, and he was quite happy. So, in conclusion, not all midfoot injuries are Lisfranc injuries. Beware of Chopard's navicular cuneiforms and dendrocuneiform joints. Early diagnosis is the key. Specific imaging and analysis should be done, and a comprehensive and individualized approach should be used. Sometimes you need out-of-box solutions. Primary fusion may be an option for such very complex cases, and always have a dialogue with your patient that it's a long haul for them. Thank you very much.
Thank you, Pradeep, for excellent presentation of complex cases. The question to you is, how do you judge intraoperatively that you have adequately lengthened both the columns, or you not over lengthen one column over other column?
Yeah, so the key is, I think, looking at your tarsometatarsal joints and other joints, and you have to bear in mind that's why incidence of so if you're doing a fusion, you have to look at the parabola, the first ray, second, third, fourth ray, and always try to get the other side X-rays as well, because that is very key. You want to make sure that the alignment is well maintained. You don't want to shorten your first ray too much or shorten the lesser rays too much as well. So I think getting if you're in doubt, you want to do a primary fusion, you want to shorten it, then always try to get the other side X-rays.
Would you, in a complex midfoot cases, would you like to paint and drape both the lower limbs?
Yeah, means if you think that yes, you are going to have a very you're thinking of doing a whole midfoot reconstruction or a fusion, yes, you can do both sides fusion as well. As I said, these are very rare injuries, but always, if in doubt, as I said, I would try to initially buy time, put in a fixator, hang on, come another day, maybe a week, 10 days later, plan properly and get all your instrumentation and implants available to you.
And how would you judge clinically that there is association of chopart injury also into this particular injury?
So again, CT scans, I think clinical examination, I think plantar flexion, dorsiflexion, rotation, check if it is unstable as well. And reading your, getting a mechanism of injury, CT scan. That's why I'd like to read all our CT scans by yourself as well. I think that's very important. And
Okay.
cuboid, don't forget the cuboids.
Yeah. So if you look at the plantar ecchymosis, which are quite proximal, then it suggests you that there is a chopart injury also. So
Okay.
not only before X-ray or CT scan, if you look at the ecchymosis, when ecchymosis are quite proximal towards the heel, it suggests that there is association of chopart injury. There's a question for you, Pradeep. What are the incidences of arthritis post such midfoot fractures?
I think less frank and I think midfoot injuries. I think the arthritis is almost 100% if it is a bad injuries. But interesting wise, the cases which I've showed, the first case which is a physiotherapist, she's almost 5 years down the line, she's not come back. So though there may be arthritic, but they not be symptomatic. So that's the key thing. That's why having a dialogue with them that yes, in future they may develop some problems and may need, if you've done a fixation, they may need a fusion in future. That should be explained to the patient very early on. As long as you do that, they are quite happy, they are quite satisfied, and they understand what the expectation from the whole injury has been. And I think all these midfoot injury, complex midfoot injuries, I think arthritis is almost 100%.
What is paramount for you? Prevention of arthritis or getting the length of both the columns?
I think getting the alignment is very, very important because if it comes in arthritis, you can just deal with it very easily. You can just do an MIS, small open, fuse it, percute screws, whichever. But if you don't get the length and the alignment right, then there's a big problem.
So very well said, Pradeep, because the length is more important than you worry for the arthritis because many a times there is arthritis which is radiological and clinical it is not symptomatic. Uh, Thank you, Pradeep. Over to you, Dhrumin, for your presentation.
Thank you.
Okay, can you hear me?
Yes, go ahead.
Yeah, thank you, Bombay Orthopedic
Make it a full screen.
Thank you, Bombay Orthopedic Society, and thank you, Dr. Rajiv Shah, sir, for inviting me and giving this opportunity. So, coming from the complex stuff of Pilon and midfoot, we'll rather deal with simple ankle fractures. They are simple to look at, but not so when you get into the actual planning and management. So, case one, two cases, one syndesmosis and the other deltoid. So, we'll see one by one. 45-year-old female, high BMI, no medical comorbidities, came with this injury. So just to describe it, there is a proximal fibula fracture, which is a Weber C. So whenever there is a Weber C, always think of syndesmosis. There should be some syndesmotic disruption. On the AP view, you can see something medially. Although there is no medial malleolus fracture, there could be something posterior-medially. Next step would be a CT scan, which I will show you all. So I have the sagittal and coronal with me. You can see the small posterior fragment, and it is posterior medial because if we scroll from the fibula to medial malleolus, it is towards the medial side. And on the coronal images also, you can see that that's the posterior medial fragment. So these are the cases where you have to be aware of the tip post entrapment, as Amber discussed in her cases. So these are the two X-rays, and how would you plan? Dr. Rajiv, do we need to ask anyone or we go ahead?
I think we go ahead and we'll take some interactive questions later on.
Fine. So my plan was definitely we need to fix the fibula here first, mean get the length, and to fix the posterior medial malleolus because I had to open up posterior medially again to see the tip post entrapment, detension it, and fix a screw. And then think whether I need any syndesmotic stabilization, whether I need any deltoid repair or so. So this was the fixation which was done, fibula plate and a posterior medial approach, relieve the posterior medial tip post tendon and fix the fracture fragment with a screw. Now this is a valgus stress view. If you see the video on the left, yeah, it's playing a bit slowly. But if you see the external rotation stress view, I'll play it again. You can see how much the talus is sliding laterally. So there is a significant shift, talar shift, as you can see there. So on valgus, it is not opening up, but on external rotation, it is opening up. So in these cases, I will think more of syndesmosis rather than deltoid. So if you see this, again, some people would go and primarily fix deltoid, which at the end, Rajiv sir can explain what would he do, or some people would fix the syndesmosis first. So I had already put the staples in the fibula, as you can see, but I had to open up the staples and plan for syndesmotic fixation. So external rotation stress, very important after you fix your lateral and medial sides to see what is going on. So this was done. That's a tightrope which was passed, as you can see. I try and keep the ankle in neutral position, a little bit dorsiflexion, and then tighten it on the other side. So yeah, ankle goes in dorsiflexion when you are tightening the tightrope. And so tightrope, you should tighten it quite forcefully rather than screws. In screws, most of the reduction is done by your thumb and the fingers, and then the screw does. But tightrope, you have to tighten it quite, otherwise it becomes slack. We have seen in a couple of cases that the tightrope becomes slack. So this was the fluoroscopic video after stabilization, and in this it was stabilized like this. So that was the post-op images of posterior medial malleolus fracture fixation, which required a syndesmosis in the end. 6 weeks, she was walking in a walker boot. She is now already 3 months. I don't have her video walking now, but that was the X-ray, and she's doing fine. So another patient on the other side of the spectrum, if we go, 16-year-old boy had this twisting injury while playing football. You can see the physis still closing up, 16-year-old almost, fibula fracture, and medial clear space opening. So you know that something is disturbed medially. So these are bimalleolar equivalent. This is not just a fibula fracture. It's called a bimalleolar equivalent fractures. CT scan again shows the same information. There is no posterior malleolus fracture here. So we are just dealing with lateral and medial. So in this case, I would fix the fibula and then again assess what is going on. So that's what I did. So fix the fibula and fluoroscopic video after that, and you can see that talar shift, the talar tilt. Now in varus valgus it was opening. However, in external rotation maybe little bit, but more while varus valgus. So here I think a direct deltoid repair is a much better thing to do rather than syndesmosis, because he's 16-year-old. You don't want to put a syndesmotic screw or even a tightrope that will restrict his playing ability. That's the medial incision over the deltoid, and you can almost see the lax tissues. You can see the rent in the deep deltoid once you dissect the superficial tissue, and you can almost see the talus bone there. And I'll play through, and you can see the instability. So it is very important we repair the deltoid in such cases to give them early better outcome. Some people would have done by not repairing the deltoid, treating it, but it needs a plaster of 6 to 8 weeks then to heal it properly. So this is a 5 mm fiber wire, and this is how the deltoid was repaired in this patient, and he had a stable ankle joint after that. So rather than syndesmosis, this was more of a case for deltoid because the talus was tilting in varus valgus. In the previous case, the talus shift was in external rotation. So that was more of a syndesmosis case. So these are the two cases. These are the X-rays. Let me just go to the next slide. Yeah, so the advantage of deltoid repair is, I think, this. So at 6 weeks, 2 weeks plaster, 2 weeks, and almost able to quite comfortably in the walker boot. This was possible, I think, only because of his deltoid fixation. A couple of more videos, but I think it gets hanged. And this is him at 4.5 months. So I think this would haven't been possible if deltoid would have left, and we would have left him heal in just a plaster. He would have got a good outcome. But if you are giving young patients the best chance to get back to their feet, this is what should be done, I think. So studies have shown that whenever the talus bone shifts, there is a 42% reduction. We have to restore the ankle mortise. First the trend was towards syndesmosis fixation, and now we are moving more towards deltoid repair. So number of articles coming, deltoid provides equivalent fixation rather than syndesmosis in bimalleolar ankle fractures. Meta-analysis again shows that primary deltoid repair is equivalent to transsyndesmotic fixation for bimalleolar equivalent fractures. What I would say, always keep a high index of suspicion. Sequence is fix the fracture first, fix the posterior malleolus, then the fibula, then assess for syndesmosis versus deltoid, which is the major culprit, and repair that acutely for better post-op outcomes. Thank you.
Thank you, Dr. Dhrumin, for an excellent point to be discussed onto. As you already must be aware about James Nunley's study, where they have proposed that even if there is a syndesmotic injury, you could just go ahead and do the deltoid fixation and you may not need syndesmotic fixation. Your view onto that?
Yes, so these are exactly the numerous recent papers, 2023, 2024, which are saying that primary deltoid repair will avoid a syndesmotic fixation. You don't have to do a second surgery to remove the screw. There is no restriction in dorsiflexion, plantar flexion, so that should be done. However, in my first case where I used the tightrope, if I do a varus valgus, there is no medial opening, then I wouldn't think of repairing the deltoid in that case. But when I do an external rotation, there is a significant talar shift. So in that case, I would do syndesmotic rather than deltoid, because even if I do deltoid and after external rotation, the talus is shifting, that means the tibia fibula is not holding together. I need to bring them together with syndesmosis. So case by case, I will assess and decide accordingly.
Yeah. Pradeep has a question.
Yes, Pradeep, sir.
Yeah, hi, Dhrumin, fantastic presentation. I think Dr. Rajiv, sir said about role of deltoid, and the deltoid, actually the first paper is almost 5 to 7 years back from JBJS, which mentioned that you can do the deltoid and you can get away with syndesmosis. But recent paper in AOFAS, FAI journal shows that there is no difference in the promise outcomes with patients who have no deltoid repair and deltoid repair. Any take on that?
Yeah, so outcomes, we have to see what outcomes they are seeing. Are they at 6 months, 1 year, or are they competitive sports at 6 weeks, or
No, it's from Manish Kadakia and Chicago group itself, and almost looking at 2 and 3 year follow-up.
Okay. So yeah, that may be true. But if we have to make a point, if we have to make a decision in theater, I think the fluoroscopic imaging, the amount of opening medially, how much you see after fixing the fibula, we should make a decision then. But yeah, if they have shown, then definitely it's a gray area whether we are repairing deltoid or not. But if we feel that that person will have a good outcome after repairing the deltoid, as shown in my case, I think we should go ahead and do it.
Yeah. And also, how often have you fixed the posterior malleolus, syndesmosis, and deltoid?
Not very frequently, I would say, but once the posterior malleolus goes in place with the fibula plate, your 70% stability is achieved. Then you assess whether you need a syndesmosis or a deltoid. And if you do the syndesmosis also, then I don't think deltoid is needed. If it is severe injury, then, but very, very rare, I would say.
It is because in your case, you did fix the posterior malleolus and syndesmosis.
Yeah.
In the first one. Yeah. Okay.
I agree with Pradeep. The studies have shown that the long-term results, either you fix deltoid or you don't fix deltoid, are same. But all those spots population, if you don't fix up the deltoid, they have problem into their push-off. and they go to the spots late. And that's why the whole pendulum is swinging towards fixation of deltoid. There are two questions from the chat box for you, Dhrumin. One is any role of MRI into that? And second question is the technique of fixation of the deltoid.
So whenever there is a fracture, I don't think there is a role of an MRI. MRI is for high ankle sprains where you don't see a fibula fracture, you don't see a posterior malleolus fracture, and you have to see the ligaments and repair the syndesmosis. Uh, that is when MRI is needed. CT is of value. What was the other question, sir? Technique of
Question is, how do you, technique, how do you repair the deltoid?
So in acute injuries, deltoid is easy. It's just a curvilinear incision under the medial malleolus and a horizontal incision in line of the deltoid fibers over the superficial deltoid. As soon as you dissect some fibers, you'll see the deep deltoid is torn away, and then you do your stress test again, the external rotation varus valgus. And then you put an anchor and take suture bites. Double loaded anchor is always better. If you're using single loaded, use 2. And bring back the whole deltoid material with the capsule, with the deep deltoid, with the superficial deltoid, and tie it over the medial malleolus.
If you have an injury where you have a deltoid plus an ankle fracture plus a lateral ligament injury, which would you repair first, lateral or medial?
So with the ankle fracture, I wouldn't suspect that lateral ligament and deltoid both will be injured. With fibula fracture, if I fix the fibula well, I would go to medial side first, stabilize the medial, and then assess again the ATFL by doing an anterior drawer, by doing a fluoroscopic view. Only if after fixing fibula and deltoid, if still I feel that ATFL is lax, then I will open distally and fix the ATFL.
I think there are cases where you have both ligaments gone, and then I think I would do the lateral first and go to the medial next. Anyway, I don't see any more questions for you. Yeah, can I ask Dr. Abhishek Kini to share his screen and start his presentation?
Thank you, sir. I shall start. So, greetings from Munich, and apologies for the background sound. I've just changed my presentation from one trimalleolar to the another trimalleolar. And the reason is because I have Agashe sir with me on this group. And this is a case which we did together under his leadership, and I was more of an assistant to him. So this is a 28-year-old male, and we see that he had this trimalleolar fracture with ankle subluxation.
Can you make it a full state? Sorry, Abhishek. Can you make it a
sir,
full
I
screen?
think this is, I'm playing it out of my phone, so I think it will come like that. Is it visible?
Yes.
The main X-ray?
But if you could enlarge it, I do not know whether you can do it or not.
Is it okay, sir, now?
Better.
Okay. So this was the fracture which he had. He had a fall in Dubai. He was put in a splint. He was reduced, put in a splint and brought to India. And he was primarily fixed elsewhere. So this was the X-ray which was there post-op. The fracture, the surgeon was not happy with it. And I'll show you the, can you see the CT scan on the other screen, which actually is my camera? You can see that the posterior malleolus is still out and is actually in the syndesmosis over here.
Mm-hmm.
So this was a trimalleolar fracture which was fixed without addressing its components. Primarily, the fibula was not brought to length. The fibula was not brought to length. The trimalleolar fracture, the posterior malleolus was not reduced, and hence the medial malleolus also never sat in place. So actually, if we kind of draw lines, the ankle mortise is still subluxated out laterally. You can see that the fibula is shortened and the medial malleolus is turned inwards. So with this information, we went in and we could go in and we had to actually revise the entire construct. We revised the posterior malleolus. We first and foremost got the fibula to length by putting interfrags in a high fibula fracture and then put a neutralization plate. Then we put a proper T buttress plate for the fibula, for the posterior malleolus. And then we could get back the medial malleolus also back in place. So this was his post-op picture. And this was his post-op CT scan. So you could see that now that the fibula is sitting back in the mortise with the proper alignment and everything. So I think this was the case that we wanted to discuss today. And now he's almost 3 years down the line. We've removed the lateral implants also because one of the screws had backed off. So I think my take home on this was that, it's important that even though trimalleolar looks quite simple, it's important that you address each and every component of it properly, like address the fibula length, understand the ankle as a ring, and address each and every component of the ring properly as compared to not just doing it properly. Then I think that's what gives you the proper outcomes in our trimalleolar fractures. Thank you. Any questions, sir?
Yeah. Thank you, Abhishek, for managing this and keeping me away from doing any other presentation. So which approach did you take for this case, and what was the position into which you did this surgery?
So we do these fractures in a floppy lateral position as we begin laterally, and we use a posterolateral approach through which we can access the fibula completely and go in between the peroneals and the FHL and approach the posterior malleolus properly. Yes, you need to take care of the sural nerve. In this case, I think we were primarily guided by the initial surgeon's approach, which he also had done the posterolateral approach and the medial approach. So floppy lateral, get the fibula to length, by putting interfrags, go behind, do the posterior malleolus, then put the fibular plate. This is what we did over here. And then turn or take out the sandbags from the ipsilateral buttock, turn him supine, and then get the fibula, then get the medial malleolus down.
Abhishek, there must be the original incision, lateral incision, which a surgeon must have put in. And then you put in one posterolateral incision.
No, sir. The surgeon had put a posterolateral approach only. We just went in, we extended it up superiorly and inferiorly so that we didn't want to put too much of soft tissue tension on the incision itself.
Been a lateral approach for fibula and miss posterior malleolus, how would you be the approach you would be going?
So I think we can still go in extending it far more superiorly and going downwards towards the fourth metatarsal base. And through that, you can actually, with the same approach, you can go anteriorly also onto the distal tibia and go posteriorly also onto the posterolateral tibia. So it's a direct lateral approach for pylons, which is in vogue and my favorite today for complex pylons.
So how would you interoperatively judge the reduction with regards to the rotation?
So when you do these fractures open reduction, I think you have to get edge to edge. In this case, it was a challenge because it was already being manipulated once. So in these cases, what we do is we make sure that we get direct reduction of the fibula into the incisura. We go anteriorly and check whether the fibula is sitting properly on anterior border of fibula into the anterior fibular insulosural notch. And we look out for the, what they call it as the Mercedes-Benz sign or the triflant sign of the distal fibula and the distal tibia. In this case, because it was a revision and things, in fact, we did get a post-reduction CT scan before we extubated him. We had that luxury in our hospital, so we could do that. But otherwise, direct visualization of the fibula into the incisura is, I think, the most assuring sign on table for a surgeon, along with the radiological signs of the dime sign and the curvilinear signs and all the thing. But I think for me, checking the fibula sitting back in the notch is very important than the C-arms.
Okay, thank you very much, Abhishek, and thank you
Thank you,
all
sir.
the speakers
Thank you.
for
Thank
yeah.
you.
And thank you all the speakers, and thank you, Arvind, for putting it all together. Over to you, Dr. Gautam, for your vote of thanks.
Thank you at the outset. Let me say thank you very much to the Asia Pacific Ankle Foot Society, Dr. Arvind Puri, for spending his evening with us, and to each and every member, Dr. Primardhi, Dr. Haseeb, Dr. Ballal, for presenting such interesting cases, combining them with good literary review so that we all went home with take-home messages. On this platform that we had today, we had about 100 people watching us live, which for a new specialty or a branch in India of ankle foot surgery is a big number. So I'm extremely pleased that all the people will take home a fantastic message. Before you leave, I would like to request Dr. Puri and the team from Asia Pacific Ankle Foot Society to consider one or two delegates exclusively from India for this fellowship that you were proposing, for which you have got funding for. In a country which has a population of almost 1.4 billion, the number of ankle foot trained surgeons are few, and we would be really grateful if some kind of an exclusivity to the fellowship could be considered. I would also like to thank my young colleagues from Bombay, Dr. Pradeep Moonot, Dr. Dhrumin Sangoi, and Abhishek, who is in Germany, presenting at an international meeting over there. And finally, my thanks to my big brother, Dr. Rajiv Shah, who every time I call him up and trouble him, and he is always ready with a smile to help me further the cause of ankle foot in India through the Bombay Orthopaedic Society. Thank you, Rajiv Bhai. I would like to thank my secretary, Dr. Ashish Fadnis, and the team from Ortho TV, who's been there and helped us run this program today, and the chairman of the executive committee, which deals with these webinars, that is Dr. Rujuta, and her team of Dr. Bijlani and Dr. Bhaviskar, who make it easy for us to organize these programs. Thank you very much to all of you. Thank you, Arvind. Before everybody leaves, I would like to request my Indian colleagues to stay back for 5 minutes. I would like to have a word with Dhrumin, Abhishek, Pradeep, and Rajiv Bhai before you all exit. So, Arvind, some final words from you before you all leave.
Oh, most definitely. Look, this has been an exceptionally good collaboration between the foot and ankle surgeons from the Bombay Orthopaedic Society as well as the APOA. And I think there is a great potential to extend this relationship and make it bigger and better. And like you said, the next step is to include foot and ankle surgeons to go and attend the fellowship in countries where they can learn as much as possible within the 2 months that they get an opportunity, and come back and spread the word. Also, an exceptional teaching session. Thank you very much.
Thank you. Thank you. I think even
Gautam,
the
we need to
conditions
thank-
that we treat are very similar. The ones which are there in East Asia are very similar to what we find in India. So it will be a great learning experience for our people. Thank you.
Gautam, we need
Rujuta,
to
you wanted
thank
to say something?
Yeah, we need to thank our sponsors as well, Torrent Pharma. Last 3 webinars, they've been really very, very, supportive of the whole thing.
Thank you, Rujuta. You're absolutely right. I forget to do this, but yeah, you're absolutely right. Torrent Pharma has wholeheartedly sponsored these webinars, and we helped us take this message forward. Thank you.
Rishi, you can
So-
stop recording.
Yeah, you can stop recording Ortho TV. I'm just going to thank you, Dr. Primardhi. As you... Yeah, so gentlemen, Pradeep, Dhrumin, Abhishek, and Rajiv Bhai, and of course Ashish, who is going to be the principal coordinator. About a month ago, we had something called as the live hand surgery course of the Bombay Orthopedic Society. In Jupiter Hospital, we held the course. These were all recorded live surgeries, and these were shown not only to audiences sitting in Jupiter Hospital, which numbered up to 100, but they were telecast live to 20 different centers across the country, where almost another 1,000 people watched them live sitting in a room. And this program, we were planning to show about 12 surgeries, but we ended up showing 17 surgeries because they just wouldn't leave. Sir, show us this, show us that. And this program, we they not only showed all these live surgeries, so the program was run this way, that initially for the first 5 minutes, the case that you are going to present was discussed, the clinical findings, the X-ray, and other investigations were discussed, and what was your surgical plan was discussed. Then over the next 10 to 15 minutes, the edited surgery was shown. And then it was opened up to the delegates across India for live questioning. This became extremely popular, and around 20, every case was discussed over 20-25 minutes. We had to forego breakfast, we had to forego lunch and tea, coffee in order to fulfill the demands of the audience. But it was a tremendously successful program. The ankle foot is another big event we are trying to have. Ankle foot live surgeries people are not very familiar with across India and are very keen to see this kind of surgery. So I'm sure that when we organize this program, it will be another big hit. Now, I had formed a group and I had written in that group and proposed a tentative date of August 17th. That is a Sunday. That tentative date still holds, but there is a problem in acquiring the appropriate venue for this. And therefore, another potential date is September 14, which is a Sunday. I spoke to Rajiv Bhai earlier in the day, and he said he was comfortable even with September 14th. I wanted to know whether Pradeep, Abhishek, and Dhrumin are okay with this date before we finalize. Else, if people are not comfortable, we'll just keep it at August 17th and look for another venue. Pradeep, are you okay with September 14th?
I'll just look at the timings and stuff, anything, because, okay.
It'll be go from morning 9 to evening 5. It's a Sunday.
Yeah. As of now, there's nothing, so I'm okay with it.
Dhrumin?
Yeah, I'm okay with it. Yeah.
Hold on. When is the C-Court? C-Court. When is C-Court?
C-Court is month before that.
Okay.
Is, I'll just check C-Court from here.
Hold on. 3rd to 5th. That's okay. 3rd to 5th September.
Okay, great. What about Abhishek?
I'm okay, sir.
Perfect. All right, great. So now we have 2 dates where we have got clear say yes from all 4 of you. And there are a couple of other peoples like Pascal, Samad Thakkar. I think Ashish mentioned somebody from Thane and Kalyan who is also an ankle foot surgeon. I forget the name.
Sham
Thakkar.
Sham Thakkar. So we will get all the juniors involved. The plan would be to show each and every case over 10 to 15 minutes. What I find is that you will need to edit your videos over 10 to 15 minutes. The plan is to show a combination of trauma and cold cases. I've put up the cold cases on our group, on our WhatsApp group. The cold cases being hallux valgus correction, the tarsal tunnel release, a subtalar fusion, an ankle fusion, and excision of a Hageland spur and a tendo-Achilles reconstruction. Are there any other cold cases which you feel general orthopods would be benefit from seeing?
So we can let them decide and come up with the list, because anyway 15, 17 cases easily videos can be shown. And
yeah, so what I got from most of them, Dhrumin has already recorded about 3 ankle arthroplasty. I forgot besides the ankle arthroplasty. I think Dhrumin has recorded 2 or 3. Most of the surgeries that I mentioned are already available with Pradeep and Rajiv Bhai. Abhishek wrote to me that he has recently lost a lot of his videos when his computer software crashed. So he's going to check and see what is available. We will discuss this in our group, but as of now, depending on the availability of the venue, one of these 2 dates we are finalizing and going ahead and starting to advertise the program. Thank you very much. We
What
can
venue
now
are we
exist.
looking at, Gautam? Which
What?
venue? Venue
Venue
where?
will be at present, if we are thinking of August 17th, there is at present, if we are thinking, then it has to be Jaslok Hospital. And September 14th, I'm trying to find out whether Jupiter Hospital is available, because Jupiter Hospital has a lovely setup, round table seating for 100 people. Everything is so smooth and this thing that it's a wonderful place. And that's the reason why I'm considering shifting the program to September 14th if necessary. So let us see how it works and we'll get back to you. We'll stay active on the group. Again, let me thank all of you for being here on this Sunday afternoon and sparing your valuable time for BOS. Thank you very much.
Thank you very much. Thank you, everybody.